Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me by a retinal specialist. This patient has had a retinal detachment, multiple surgeries, and now has a very dense cataract, a tiny pupil due to posterior synechiae, about a 1 millimeter pupil, shallow anterior chamber, which signifies loose zonules, weak zonules. And so you're going to see how I'm able to get through this cataract. This is obviously going to require multiple steps, and you're going to see at each step what I'm going to employ in order to execute this surgery, and of course performing lens disassembly techniques in such a way that will minimize risk and maximize efficiency in this really difficult and challenging situation. So as you can see, this pupil is tiny. This patient did receive dilating eye drops, but of course you can see that there seems to be no effect. So first things first, we have to open up the pupil. So I always start with a subincisional incision, which is going to be going underneath my main incision, and it's going through the episclera and sclera, but it's going to make sure that I have a hook into the subincisional area so that I don't encounter any iris prolapse throughout the case. I'm going to have 5 hooks, and then I'm also making my incisions, one on the right and the left side, for the cataract surgery. And you can't appreciate it here, but this patient has almost no anterior chamber. It's a very shallow anterior chamber, dense cataract. I'm putting some intracameral epinephrine. Of course, it did nothing. And then I'm gently sliding this iris hook. And you have to be mindful that you can catch conjunctiva when you put that hook in. You want to twirl the stopper so it points down, catch the edge, just like when you're catching a fish on a fish hook, and then you pull it, and then push the stopper down. And doing the same thing on this other one, adjacent hook. You want to twirl the stopper so that the hook points down, and then engage the edge there. As you know, I always like to put the hooks in before I put viscoelastic, because if you put in viscoelastic first, in many cases, it pushes the iris all the way down away from you, and it's harder to get to. Again, I'm rotating the hook down and then cinching it down. Hold it perpendicular. Here I noticed that the actual hook was broken. These are brand new hooks, and so I feel like there's some manufacturing issues with these hooks. They shouldn't be broken, but you'll see here as the case progresses, I have a few hooks where they're broken. The actual blue part of the hook is not intact. And so you see I'm just trying to thread the stopper on the broken piece of that hook. So yeah, I mean, obviously that's not something you can control. We're going to send this off to the company, let them know that we had these issues. Again, brand new hooks. And then this is the last one. Again, you want to hold it perpendicular. And you'll see here, actually, this is a broken hook. And so I don't want to pull the stopper back because it'll basically break here. And so I'm just very carefully trying to push it in. Oh, you see it broke. So I knew that it was broken. So I can still use it though. I'm holding the stopper and then I'm pushing the hook into the stopper and then withdrawing and retracting each one. So there we go. So this is some intracameral air. You can see there's basically no air, very little air going in, and that's because it's so shallow. Going to paint trypan blue on the anterior capsule surface. Again, I tried to avoid overfilling the chamber with dye because it can go into the vitreous space. So I prefer to roll the dye on the anterior capsule surface like a paint roller on a wall of a house. And this is intracameral dispersive viscoelastic to push the bubble as well as the dye out. trying to flush some of that dye. And this is my keratome incision. I could have made the incision before I put the hook in, but I go ahead and just make my incision now. Again, hard to appreciate how shallow this chamber is, but it is shallow and the lens is bulging forward. This patient probably has some level of zonulopathy, and you'll see that throughout the case. Remember, a shallow chamber is an indication of weak zonules in some cases, especially patients who've had multiple surgeries. Their zonules tend to be weak. So this patient's had retinal surgery, so clearly it's likely that this patient has zonulopathy. And as a result, you can see I'm going to make my rhexis a little bit on the small side. When you're dealing with these tough cases, you don't want to make a giant rhexis, because what if the bag is not stable and you have to use a CTR or a CTS? You have to have enough of an anterior capsule rim in order to be able to support those devices. And so you can see I'm making a smallish rhexis. But the next thing is you need to be able to handle a smaller rhexis with your lens disassembly technique. Some people make giant rhexises because they need to do that for their technique. But again, if you have a technique that is limited because you have to make a big rhexis, then when you have these tough situations, it's probably not the best thing, especially when you have a shallow chamber and a big lens and there's radialization forces for the rhexis. You don't want to make a huge rhexis in that context. So this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally. Of course, it's hard to see if there was a wave or not. Such a dense lens. And you can see the capsule is moving quite a bit. Again, echoing and verifying that there is some zonulopathy here. Again, I'm being very gentle with the hydrodissection, but yet you can see the anterior capsule rim is moving around quite a bit. Again, suggesting that there's probably some zonulopathy as well. So I'm not perseverating. I'm not going to try to spin the lens and cause more zonular damage. So I go in with irrigation off, activate irrigation, lifting the incision, removing the surface epinuclear material. And then I'm going to go bevel up, and I'm going to go ahead and sculpt, and I'm going to do a terminal chop technique. This is a dense lens. I don't want to take a chance. Small pupil, zonulopathy, shallow chamber. I want to be able to efficiently break down this lens. So I'm switching to the dense mode, and then I'm going to sculpt a trough, debulking the central dense core. By doing it that way, I'm able to efficiently then separate the lens into heminuclei. And the reason being is by doing terminal chop, remember the lamella are in concentric fibers. So if I'm able to fracture the terminal side, I'm effectively fracturing the lens through and through, and that fracture point will propagate to the posterior lamella, and therefore bypassing and overcoming any potential posterior plate phenomenon, as you see here. So through and through fracture with the terminal chop, placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it center toward the phaco tip, fracturing the lens against the phaco tip, and that is the cross chop. Using the chopper to get around that first quadrant, crushing the lens in half, that is another cross chop maneuver, lifting that piece up and then crushing it between the instruments and then emulsifying the lens piece. Loosening up that second quadrant, grabbing it with some vacuum, lifting it up, crushing the lens piece between the instruments, and then emulsifying the lens piece. And because I use sparing amounts of ultrasonic energy and vacuum, and I'm just fracturing the lens under irrigation pressure, it's a very controlled way to systematically disassemble the lens. Turning that second heminucleus in front of me, placing the chopper around the lens equator, contra-incisionally, again, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip, another cross-chop maneuver. Doing the same maneuver against that third quadrant, hooking the peripheral lens, crushing it against the phaco tip. And then now smashing the lens between the instruments, and then using pulses of ultrasonic energy and vacuum to emulsify the lens pieces. You can see I have tremendous control as I'm doing this case. I don't feel nervous about what's happening. There's no trampolining. And you see how nice the iris hooks are in this context. I have complete control. I'm able to customize and titrate the amount of tension on the hooks. Very versatile way to do this type of surgery in this challenging situation. Fracturing the lens into smaller and smaller pieces, using my instruments to crush the lens pieces. And then when I'm ready to eat the pieces, pulse it with some ultrasonic energy and vacuum. By keeping the bevel down and directing the forces at or below iris plane, I'm able to reduce ultrasonic energy exposure to the corneal endothelial cells. I'm also not going to remove the dispersive viscoelastic that's coating the corneal endothelium, thereby protecting the cornea better by keeping that bevel down and below the iris plane. You can see the endonucleus is all gone. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I chose not to go with the phaco tip to remove the epinucleus. And why? Because I already feel like there's weak zonules and the posterior capsule is probably floppy. And what you don't want to do is use high vacuum to remove the epinucleus. And if the epinucleus is attached to a very floppy posterior capsule, you can accidentally eat the posterior capsule and then end up with posterior capsule rupture. So although using the phaco tip would be rather efficient to get that giant epinucleus out, by switching to IA and using the polymer tip, your risk of having posterior capsule rupture with epinuclear removal is going to be so much less. Yes, it's going to be slower, but this is going to be much more methodical, slow, and safe to remove that epinucleus. You can see here, very carefully, slowly teasing off the cortex and epinucleus, starting from subincisional and going around circumferentially, and just gently teasing off that epinuclear material as well as the cortex. Again, using the phaco would have been efficient, but having that phaco tip, metal tip, with high vacuum, and unfortunately, again, the posterior capsule can follow the epinucleus, especially if they're adherent to one another. And I know there's going to be a floppy posterior capsule because of the zonulopathy that I saw before. And so really, this is a better way, a safer way, much more controlled way to remove the epinucleus as well as the cortex. I switched to polish mode now, just trying to very carefully polish. And you can already tell this bag is not stable. You can see the anterior capsules fluttering. You can see the rhexis is actually fluttering under the currents of the infusion pressure. I'm just very gently trying to tease any lens remnants. But you can see how floppy it is. Again, all of these are preparations, right? Again, in the beginning of the surgery, shallow chamber, dense cataract, history of RD surgery, you're going to have zonulopathy. I mean, if you do enough of these cases, you see patterns. And so as a result, very gentle technique, lens disassembly technique. And again, I switched to IA early to remove the epinucleus and cortex. Again, you saw I pulsed the BSS with a cannula. You can see how much the capsule flops around. Again, just validating and echoing those signs that there is zonulopathy. Turning off irrigation, filling the bag with cohesive viscoelastic. And then we're going to go ahead and switch to the sweep, polishing under the rexus edge of lens epithelial cells. And this is why I like to do the kind of pentagon shaped iris hooks. I like to have 5 hooks. It gives me the best exposure. And so this is a CTR, again, pointed down. And then with that eyelet, I like to kind of lift it up, make sure that it's sticking up above that platform, and then hooking the eyelet and then letting it go into the injector. And then using a Lester, I'm going to lift the incision, go in, and then using the Lester, I'm going to hook the leading eyelet. And as I push the injector, it's going to minimize any torsional stress on the capsular bag. Once I have the trailing eyelet come out, I pop it into the bag. An efficient way to do it, again, minimal torsional stress on the zonules. Widen the incision because I'm going to put in a 3-piece lens. Invariably, you're going to cause some OVD to come out, so I push some more OVD before I put the lens in to make sure the bag is completely expanded. Making sure the leading haptic goes into the bag, rotating my wrist, pronating it so that the optic comes out flat, and then I'm going to dial the trailing haptic into the bag. So again, I feel like I'm putting maximal support for the zonules. I put in a CTR, I put in a 3-piece lens. Now we're going to take the hooks out. This is an easy technique. Grab the proximal end of the hook, pull the stopper back, disengage the pupillary edge, and then you want to rotate it 90 degrees in such a way that the free end comes out last. Yep, just like that. When you do it that way, you can preserve the hook. Obviously, some of these are broken, but normally you can use these hooks up to 3 times, I believe, autoclaving it. So you're able to preserve the hooks this way instead of just yanking it out. If you yank it out, you're going to break the tip. But if you rotate it like I do all the time, it pops out nicely. Go in with irrigation off, activate irrigation, getting underneath the lens, removing the viscoelastic from within the bag, repositing the optic back, polishing under the rexus edge, switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a dense cataract, a secluded pupil, basically a 1 millimeter pupil. I had to put iris hooks in to open up the pupil. Shallow chamber, which indicates potentially zonulopathy. I went ahead and used trypan blue because of the density of the lens. Again, doing a paint roller effect by rolling the dye on the anterior capsule surface, minimizing exposure of the dye to the posterior segment, and then placing a capsular tension ring, again using the Lester to hook the leading edge to minimize torsional stress on the bag, and then putting a 3-piece lens in at the end. You saw how I put the hooks in and take them out in a very efficient and controlled way. And so this case could have been an absolute nightmare. Obviously, it took quite some time, lots of steps involved. This is the patient's only eye, it's monocular. And so it's very important that you come in with a strategy. You can't go in here treating this like a routine case. You got to think about these cases ahead of time, come up with a plan of attack, always have a plan B and a C in case something doesn't go quite right. And of course, extensive preoperative discussion with the patient. This patient, because of their retinal issues, already knows that the vision may be limited, but the retinal surgeon needed to have the cataract removed because the retinal surgeon couldn't examine the retina properly. So this is really a diagnostic and therapeutic cataract surgery in this patient, again, with a complex cataract situation. You saw how I was able to disassemble the lens very confidently and carefully and methodically, minimizing ultrasonic energy and vacuum. This patient, incidentally, I saw him the next day, had a crystal clear cornea. Again, when I say these things, I'm not exaggerating. These techniques do allow me to perform more efficient and safer surgery on the corneal endothelium. And because I'm using mechanical fracturing to fracture the lens pieces rather than using ultrasonic energy and vacuum. I feel every time I have these cases and I see them post-op, and when they look so good, it again just validates what I say all the time, to leverage mechanical forces when you want to deal with cataract surgery, in particular when you're dealing with challenging cases like this. So I hope this was helpful to you, and I thank you for your attention.